We're going to talk about headaches. And this is a study you may have come across before. Dr. Ellen Bogan actually references this paper in his talk when he talks about the global burden of neurologic disease. So over here on the left is disability, over here is death. And when you look at the causes of disability or death due to neurologic disease in the whole world, you can see that stroke is by far the leading thing. But if you look over here in the disability section here, migraine is number 2. And in fact, for people who are aged 50 or less, migraine is the number 1 cause of neurologic disability in the world. I think it's fascinating that meningitis is still quite high with disability and also with mortality, dementia. You can see here that medication overuse headache ranks pretty high, and that even tension type headache gets a sliver here when we talk about disability. So when we talk about headaches, you hear people talk about primary versus secondary headaches. The primary headaches, and there are dozens and dozens of them. I think the International Headache Society describes 100 or more types of headaches, several hundred. But this is where we think about things like tension type headache, migraine headache, cluster headache. The secondary headaches are the types of headaches that are due to some other cause. And so the classic is medication overuse headache. But there are also things like post-traumatic headaches, malignant causes, things like tumors, bleeds, aneurysms, infections, and these are the things that you want to look out for. And so, you want to keep your ears open, your eyes and ears open for any kind of atypical things that may make you think that there's a malignant cause that needs to be identified when you're talking about these patients. So when we talk about the common headaches, most common by far is tension headache. And I'm going to guess many of us have had a tension headache before. And then migraine headache, a little less common, more female predominance for sure with migraine. And then actually medication overuse is number 3 when we talk about the most common types of headaches. One that's not common, but we're going to talk about it anyway because it's beloved by the people that write NBME questions, is cluster headache. So you guys know all of this about tension, I'm sure. So typically the severity is described as not quite as intense as something that you might get with like a migraine or cluster type headache. It tends to be bilateral, can kind of be behind the eyes. Sometimes people talk about a band, pressure, dullness, fullness. You tend not to get that phonophobia, photophobia, nausea, vomiting kind of picture that you do with migraine, and these can typically last minutes to hours. So compare that to migraine, where again there's a female predominance, quite a female predominance. So we know about aura. It turns out that's only a smaller proportion of patients with migraine that get aura, maybe 20 to 25%, depending on where you look. The duration of migraine is longer, a bit longer than tension. It can last hours to days, and there's actually this awful condition called status migrainosis, which is a migraine that's been going on for 72 hours. It's usually unilateral, but it can be bilateral. And when you see kids with migraine, they're more likely to complain of bilateral headache. Nausea, vomiting, quite common, and photophobia, phonophobia, quite common. The pain, people will describe this throbbing or pulsating kind of quality to the pain, not this dull, vice-like kind of thing that you hear about with tension. And the intensity tends to be more severe as well. For what it's worth, compared to cluster, as we'll see a little bit later, pain is exacerbated by physical activity. And so, the classic thing that migraine sufferer wants to do is just go to a dark room, pull the blanket over their head, make sure there's no light, no sound, and just lay there, don't move. Okay, so migraine is actually a very complex phenomenon, and it has multiple steps. Not every migraine or every phenotype of migraine is going to have all of these steps, but oftentimes there is a prodrome that can start in the days to hours before the attack. And then there's the aura, if it's going to happen. And remember, most don't have the aura, but the idea with aura is that you get these gradual kind of neurologic changes. And most common are these visual changes that we'll talk more about in a moment. But people can also get things like sensory changes, auditory changes. Some patients get weak. Some patients get aphasic. But it's a gradual kind of a process. Usually, the aura precedes the headache, but there are cases where the aura can co-occur with the headache. And sometimes you actually get people who develop a kind of migraine, either all the time or some of the time, that it consists of aura without headache. And we typically call those something like asaphalgic migraine or ocular migraine. Then, of course, the headache, which again can last hours to days. And then you get this postdrome, where you just feel terrible for quite a while afterward. And so you can see, this is a pretty complex, lengthy process, and you can see how this could really contribute to disability. These are just some artist renderings of the visual aura, types of visual auras that you can see with migraine. And so classic are these fortification lines and this scotomas, these blurs, these scotomas, sometimes distortions of color. Some patients get even more complex kind of visual phenomena than this. Some patients get a hemianopsia. Some patients get vision loss in one eye. So all quite distressing things. Okay, so migraine, we really don't have it quite figured out yet. As far as what causes it, there's clearly a genetic component there, but it's not quite straightforward at least for most kinds of migraine. There is for sure a higher prevalence in women, and then so we know hormones play a role. And further, we know that some women get their headaches with their menses. There's a particular kind of migraine that occurs with menses. And then many women, thankfully, get a reprieve from their migraines during pregnancy and so forth. So there's a hormonal component there. It used to be thought that this is a neurovascular disease. The blood vessels in the head, they get big and then they clamp down, and that's what causes the pain. And surely there are changes that happen to the diameters of the blood vessels during migraine, but it's not the underlying etiology. And so what we've learned over the past 10 years or so, is that one of the things that happens with migraine is this cortical spreading depression, where you can get this depolarization and then this hyperpolarization that spreads gradually throughout the whole brain, and it actually affects the function of the neurons. So it's thought that helps explain the aura. So we have a ways to go on understanding migraine. I think many people who have migraines can identify specific triggers. You can read them on your own. A lot of times they're things that are very good, like caffeine or chocolate, two of my favorites. Okay, cluster headache. And again, I don't tell you about this because it's so common and you're definitely going to see it. It's more, this is something that shows up on board exams a lot. And it's also a fascinating disease process. It kind of offers you a little bit of an insight into some of the variety of headache. I mentioned that the International Headache Society recognizes dozens, maybe hundreds, I don't know, of headaches. And one of them is a class of headaches called these hemicranial autonomic cephalgias, of which cluster is one. And they're fascinating. So cluster, there's a male predominance. It's unilateral, tends to be based right behind the eye. The quality is described as throbbing, and you definitely see these autonomic features. So autonomic features, you can get red eye, you can get tearing, you can get a Horner syndrome, you can actually get the ptosis and the meiosis, you can get runny nose, rhinorrhea, all that good stuff. And so it's very striking, and it's on the side of the pain. They tend to be short in duration, especially relative to migraines, but people can get multiple headaches in the course of a day. And they tend to occur in clusters, so these headaches can come, occur in a cluster, remit for some period of time, and come back. And when they do happen, they tend to happen in this very strong diurnal setting, and so it'll be at the same time of day. And so it's thought that there's this actually hypothalamic involvement in these headaches. Patients with cluster headache may get restless and agitated, so this is different than your migraine patient. So rather than going and hiding from the light, they may be punching walls or thrashing around, pacing, because the pain is so bad and the activity doesn't seem to make it worse. This is Dr. Netter's rendering, as you can see. There's also, besides male, there's also an association with smokers. And I think one of the classic phenotypes you hear about is a middle-aged male smoker. All right, so two other primary headache disorders that are exceedingly rare, rarer, I would venture to say, than cluster. Hemiplegic migraine. So this is a kind of a migraine where there's a strong family history. These are autosomal dominant. They're channelopathies, and they're pretty rare. And so patients will actually become hemiplegic, varying degrees of weakness on one side or the other, prior to or during their headaches. So you can imagine that would be a very distressing thing, but that once you realized that it was this condition, that would be very reassuring. There's another type of migraine, basilar migraine, that can also be quite distressing, as if migraine isn't distressing enough. But the symptoms are more posterior fossa type symptoms, brainstem symptoms. So patients can get vertiginous, they can have dysarthria, they can have fluctuations in their consciousness due to involvement of the reticular activating system. So these kind of, unusual types of presentations of migraine are thought to carry a higher risk of stroke, and it's generally recommended that you avoid triptans in any of these patients because of the potential to precipitate a stroke. Okay, so I think we already talked about this. Let's talk about some red flags with secondary headache disorders. So definitely, if you have a new type of a headache or a new onset of a headache or new type of a headache, a change in your headaches later in life, say after age 50, age 60, certainly above that, then you're going to want to consider imaging. People generally do not develop migraine in their 50s, 60s, 70s, and so be careful ascribing a new headache to the onset of migraine. You'll want to make sure there's not something else going on. When you hear this code word, worst headache of life, aka a thunderclap headache, these are headaches that are very severe, intense, not like nothing in intensity. It's like nothing the patient has ever experienced before, and they'll often tell you that. And it reaches its peak intensity within seconds. So it goes from 0 to 60, like that. There's none of this gradual progression like you get with migraine. It's very fast. So that makes you worry about something very catastrophic. Specifically, it might make you worry about a ruptured aneurysm and a subarachnoid hemorrhage. And so these patients must be imaged. And if the imaging is negative, they should have a lumbar puncture to look for blood. All right, anyway, so change in consciousness, that would be a good reason to image, and abnormal neurologic exam, of course, too. Patients who have kind of this picture of, fever, chills, malaise, weight loss, etc., that might make you to think about something like an infection or a malignancy, and so I would definitely image these patients. And sometimes these things can be kind of subtle, so have a low threshold, especially in older patients or patients who have risk factors. So when we hear about headache, that is worse when supine, laying down, and it's worse at night, maybe comes back, the headache comes back when the patient is up and awake. Maybe the headache awakens them from sleep. That's very worrisome for a high pressure headache. Meaning that there's high intracranial pressures due to some space-occupying lesion. And so that's kind of the classic list of things that you may think about or hear about when you're talking to somebody with a potential high ICP, intracranial pressure issue. It makes sense from a gravity standpoint why the headache would get worse when we're supine. But one of the other reasons that headaches can get worse when we're supine, when you have a lesion in your brain, is because many of us hypoventilate when we sleep. And what does that do? Well, that it makes the blood vessels dilate, and that can contribute to headache. And so, especially when you already have a space-occupying lesion in your brain. So these patients I would definitely image. You can have the converse problem, so where the headache is worse when you're upright. So it goes away when you're laying down, and then it's worse when you're upright. And this is, when I hear about this, that usually makes me think about something like a dural leak. Maybe it's from a lumbar puncture. That would be the classic thing. But it could also be from trauma or from a recent spine or brain surgery or whatnot. And so these might be patients that would benefit from having perhaps some IV caffeine, which can help with the CSF production, or perhaps even a blood patch to help alleviate the pain, versus if they had a surgical procedure, maybe sending them back to the surgeon. Okay, headache that's worse when you cough or bear down. So when you hear about that, you should think high ICPs, and you may specifically think of patients with a Chiari malformation. So if you haven't come across this condition yet in your studies or in your clinical work, take some time to learn about Chiari malformation. Specifically, Chiari type 1 malformation can be associated with these syrinxes in the spinal cord. But the Chiari malformation, one of the classic kinds of headaches that you hear about are these headaches upon coughing or bearing down, so-called tussive headaches. So immunosuppression, if you have a patient who's immunosuppressed, you could have anything growing up there. And so you should have a low threshold to image. And also patients who are coagulopathic, you should have a low threshold to get a scan. They maybe have like a chronic subdural that's been brewing for some time, that's getting bigger and bigger and becoming symptomatic. All right, medication overuse headache. So this is sometimes called rebound headache. So you'll see different thresholds for when it becomes overuse, but it seems that there's a lot of individual variation to me. So, in general, you're thinking about somebody who's having to use an analgesic more than 2 or 3 times per week. So the worst offenders are opiates. Also these butalbital containing medications like this, so Fioricet or Fioricet with codeine. So this little goodie here, this is butalbital, so it's got a barbiturate, it's got acetaminophen, it's got caffeine, and it's got codeine. So there's all kinds of stuff in this. You can still find these medications being prescribed for headaches, and when patients get them, they love them, and they're very hesitant to give them up, even though they may be causing a rebound headache. I should say caffeine also can contribute to headaches in its own right, and again, overuse of acetaminophen can cause medication overuse headache, as well as other over-the-counter analgesics like the NSAIDs. Triptans, so if you're somebody with migraines and you're taking triptans too frequently, that can give you a medication overuse headache. So what you can sometimes hear patients talk about when they've developed a medication overuse headache, the way they describe the headache is that it's this chronic daily headache, and it might lose some of its original features. So for example, if somebody has migraines and they're taking a triptan too much, they can develop a headache that kind of loses some of its migraine features, a chronic daily headache that loses some of those migraine features and kind of morphs into this other thing. So how do you manage medication overuse headache? These are tough. Usually you have to withdraw the offending medication, and you can imagine that would be really tough. It's really scary to patients, and patients become very devoted to their medications. You can consider doing a steroid burst to kind of buy them some time, get them over that hump. And at the very same time, I think I would begin a preventative medication. So give them a steroid burst, start a preventative medication so that when they come off the steroid, it's had a few days in their system. High risk for relapse with these headaches. They're tough ones. Best is to avoid letting them happen in the first place by educating patients and avoiding things like opiates and avoiding these combo drugs like I showed you. Okay, so how do we manage headache acutely? And we're talking all types of headaches. So acute management of all headaches, boy, acetaminophen and NSAIDs, those are actually quite useful for many of the types of headaches you're going to come across. And sometimes you use them in combination if the headache's really bad. For migraine, you have those as well, which many people get relief from, even with migraines. But you also have Triptans, the Triptans. We'll talk about those more in a moment. You have the ergots. We're not going to talk about that because you're not probably likely to see them too much. And then you also have these dopamine agonists, these old school drugs, Reglan and Compazine. So those are drugs that are used for nausea, vomiting, and so they can help the patient with those symptoms. We're talking migraine patients, but they can also help the headache itself. And so that's a good thing for you to remember if you're going to be seeing migraine patients, as many of us will. So migraine, another thing to remember about the acute treatment of migraine is that if you give a triptan with something like naproxen, so an NSAID and a triptan, they seem to have synergistic effects. So taking the two together can be very effective. How do we treat cluster? Well, you guys know this. So you can treat with triptan, and you can also use 100% oxygen. Okay, in general, you want to try to avoid opiates, right? Sometimes you can't avoid it, and certainly there are instances where it's totally appropriate, like a patient's just had a craniotomy or whatnot. But, you want to be careful that you don't contribute not only to rebound headaches, but to addiction and dependence and all that. And also, opiates really just are not great headache medicines. Okay, so Triptans. So these are serotonin agonists. If you are giving them to a patient who's got a lot of other serotonergic medications on board, then you might want to back off on something serotonergic so you don't precipitate serotonergic syndrome. They come in a lot of different formulations and brands, and because of the nausea and vomiting, you get these things like injections, inhalants, different kinds of ways to take it, orally dissolving tablets. These in general are contraindicated for people with certain kinds of cardiovascular and cerebrovascular disease because it's thought that they can, in changing the caliber of the blood vessels, precipitate stroke or ischemia. Okay, so now this is pretty new within the last year or two. We've got these acute migraine treatments. So for patients who can't tolerate a triptan due to their medical disease or they don't get relief from it, we've got these new medications, these G-pants. G-pants, I don't know why they call them G-pants, but they're these calcium G receptor, protein receptor antagonists. You guys maybe know more about this than I do. Maybe you studied this in pharm. But there's a couple of them. They're pills. And then there's another class of medications that we can use now, and these are these Ditans, which I think are also pills as well. And these act in a triptanish way to bring about relief from acute headache. And allegedly, I am hearing that they maybe don't really cause medication overuse, rebound type of thing. So wherever you are, but especially if you're working in the emergency department, it's good for you to have a toolkit, right? So if you have somebody coming in with a very severe headache, of course you're going to, do your ABCs, see if you need to investigate the cause of the headache, but then you're going to try to bring the patient some relief. And so here I just want to talk about a few things that you can keep in your toolkit to consider giving a patient who's having a terrible headache. And this is specifically a patient for whom you can give IV medications. So one thing to consider is to give IV fluids, and I'm sure a lot of people automatically do this anyway, but if you've had somebody, say, with a migraine who's been barfing for the past day, they're going to get really hypovolemic, their meninges are going to sag, that's going to make the headache worse, so resuscitate. And that can really help. Ketorolac, so this is an NSAID that you can give IV or IM. This is Toradol, and it's really effective for a lot of different kinds of headaches. You may need to avoid it if a patient has renal failure or they're elderly, but if you can give it, you'll get a lot of, odds are you'll get a lot of relief with it. Antiemetics, so we talked about Reglan and Compazine. And those are specific for migraine, right? So IV fluids, Toradol, you can give to any kind of patient. But Reglan and Compazine, those are more migraine focused, and they can be very effective. Some people like to give Benadryl along with those, not only to counter some of the extrapyramidal effects, but also to bring on some sedation. So, if I had a migraine patient in the emergency department, they've been miserable, it's been going on for almost a day, I would probably give some IV fluids, some Toradol, and you can repeat that, and then begin some Reglan, and then probably some Benadryl too, not only to prevent side effects, but to let them sleep a little bit. Some of the other things you might consider, depending on the circumstances, are Depakote, valproic acid. So you know this as an anti-epileptic, but it also has anti-headache properties, and it's particularly helpful for migraine. It can cause some sedation, which isn't a bad thing if somebody's having a bad headache, and so you can consider using that in addition or instead of anything above. In general, we tend to avoid this medication in women of childbearing years because it's highly teratogenic, what that's worth. And then steroids. Steroids may help if all else fails. And then I should mention, some of these you're not going to necessarily want to give to elderly patients. So diphenhydramine, anticholinergic, something that you generally try to avoid in the elderly. Same with steroids. All right, so we're not going to go through all of this, but in general, you guys know all this already. In general, when you're starting a medicine on a non-emergent basis, you want to kind of start low, go slow. There's this temptation to throw a bunch of medicine on all at once, like start 10 different kinds of medicine all at once because the headaches are so awful. But there's a downside to doing that, in that, if somebody gets relief, you don't know what medication did it. And if a patient gets side effects, you don't know which medication caused that. And so patients, if you can counsel patients and being systematic, and then reminding patients that they really do have to give a trial to these medications if possible. And then also remember that there's more that you can do than just drugs. I know I talk a lot about drugs here, but patients can also optimize their headache hygiene strategies, and they can also investigate some of these non-pharmacologic approaches. So headache hygiene, all this good stuff. So some of the non-pharmacologic approaches you've got here, some of the things you may not have heard about. There's Botox, which you may know is approved for chronic migraine and can be pretty effective for a lot of patients, apparently. But you can also consider a sphenopalatine ganglion block. And then not just migraine, but other types of headaches as well. You can consider an occipital nerve block, especially if there's a lot of pain here in the back of the neck. And then this little thing, I guess, was just recently FDA approved. I'm not really sure much about it, but you may be seeing it more. It's this supraorbital transcutaneous nerve stimulation, and apparently it purports to not only treat headache acutely if you put it on acutely, but it can prevent headache if you do it regularly. I'm sure it's very expensive and maybe not covered by insurance, but it's nice to have other things you can do besides take medications. So here's Botox down here, some of the injection points for an occipital nerve block here. And again, this can be really helpful, especially, for different kinds of headaches, but especially for those headaches that seem to start back here. and then the sphenopalatine ganglion block. Okay, so now we're back to talking about medications. So what kind of medications can you use to prevent migraine? So here we're going to specifically talk about migraine. So preventative medications, these are the best as far as having been studied. So Topiramate. Topiramate is an anti-epileptic, and at the higher doses that we use it as a seizure medicine, it's got some pretty tough side effects for a lot of people, mainly cognitive stuff. But at the lower doses that we use for migraine prevention, people tend to tolerate it pretty well. And so it's worth a try. And it can be quite effective. And so, usually it's dosed twice a day. I would definitely start somebody low and build up slowly to make sure they're tolerating it. And besides cognitive effects, some of the things you might want to watch out for are paresthesias. It's a carbonic anhydrase inhibitor, so it can cause some of these tingling sensations in arms and legs, and so you'll want to warn patients about that. It can be associated with weight loss. It's a sulfa drug, and it can exacerbate the risk of kidney stones. So there's a few things to talk to your patient about. Depakote. Depakote has anti-migraine properties, not just acutely, but prevention-wise. Again, though, it's highly teratogenic, and so that may really eliminate its usefulness for a lot of people. Propranolol, and the beta blockers in general, we've used them a lot, and some people get great effect from them. They can be tough drugs to take, not only because, in the case of propranolol, you may be having to take it a few times a day, but you may get orthostasis and some of the other stuff that comes with beta blockers. Now we have this new treatment. So we talked about the G-pants a few slides ago. These are related. These are the calcitonin gene-related peptide monoclonal antibodies. So I'll talk about those in a second. They're pretty exciting. And then Botox, of course, for chronic migraine. So these guys here, they've been around a couple years now, maybe, and these are injections that you give yourself, and I can't remember, I think some of them are last a month, and some of them are more like quarterly, but they are approved not just for migraine, but also for cluster, and they do have some potential contraindications, so you'll want to check that, of course. And I think there's supposed to be a comma between pulmonary and psychiatric. Okay, so that we talked about first line. What do you do for migraine? These are the second stringers, or less. So Tricyclics. We'll talk more about those in a moment. Sure, venlafaxine. I've never really gotten much relief on that when I've used it for migraine. And then SSRIs. So not really great options, but things that you may see tried. So children, they tend to rely a lot on cyproheptadine, which is an antihistamine. And during pregnancy, you may, if you have a woman that you're treating who doesn't get much of a relief from her migraines during her pregnancy, it may need something like verapamil. Okay, so now let's talk about preventative medications for all kinds of headaches, not specifically migraine. So here's where you see these tricyclics again. So the tricyclics were used, before as antidepressants at higher doses. In the high doses, they're tough to tolerate for a lot of people because you get a lot of sedation and anticholinergic side effects. We use them at smaller doses for pain, and not just for headache, but also for things like neuropathic pain and other kinds of pain, and they can be quite effective, especially if people are having trouble sleeping too, because they can make them sleepy if you take them at bedtime. So we definitely do use that a lot. These are definitely good ones to start low and go slow, as you titrate up. I usually begin amitriptyline 25 milligrams a day and increase by 25 milligrams every week or two until they get relief, or we hit 100 milligrams. Gabapentin, so Neurontin. This is a medication that we use a lot because I think it's easy to give. So it doesn't interfere with a lot of medications, and it's not really a deal breaker for a lot of people's other medical conditions, it is renally cleared, so you have to be careful on the dosing in patients with renal failure. But it's in general well tolerated. You can administer it, I think, up to 6 times a day. Some people take it only at bedtime. Some people take it twice a day, 3 times a day. And again, start low, go slow. And for some people, it brings relief, and that's great because it's a pretty easy medicine if it does work. But there are plenty of people that don't really respond to it. If you're going to give it, of course, you're not going to emphasize the fact that somebody might not respond to it because you want to build up some confidence in the medicine. Okay, so anyway, things that you can do specifically for cluster medicine or for cluster headache is verapamil, and then these CGRP monoclonal antibodies. This is prophylaxis for cluster headaches. Oh boy. So sometimes you get people that want to take natural remedies. These are, some of these are kind of tricky. You want to be careful. Probably the one that you would see most and that I would reach for most if somebody told me that they wanted to go this route, probably be riboflavin. I would definitely be careful with butterbur because there's some potential for carcinogenicity. And then sometimes patients will bring in these bottles of formulations that contain a bunch of different stuff, but you want to look those over. And some of them are proprietary and you can't tell what's exactly in there, so those you might want to avoid. Okay, so that's the end. The cases are going to be incorporated elsewhere, but that is the headache talk, and I hope that you managed to stay awake, and I hope that this was helpful.